Hi, everybody. My name's David. I'm a consultant neurologist from Sheffield, and it's my pleasure today to introduce you to this webinar. There's just a couple more people logging on, so I think we'll give it 1 minute and then we will make a start in earnest. Great. Well, I think that is everyone who is logging on, and look, it's a fantastic attendance today. My name's David. I'm a neurologist from Sheffield, and it's my pleasure today to introduce this webinar, Fatigue in MS. Do we really understand this hidden symptom, and how are people with multiple sclerosis being managing during this pandemic? I'm the chair, but I'm delighted to have an all-star cast to really help me unpick this very difficult symptom for our patients and for us to help our patients manage. I'm joined today by Emma Talentire, who's a clinical senior lecturer in neurology at the University Hospital of Wales in Cardiff, Joanna who's a specialised neuro-occupational therapist who has a lot of experience in helping people with multiple sclerosis deal with fatigue symptoms. And lastly, I'm delighted to introduce Zoe Steele, who is an expert patient who'll be taking us through some of her experience with fatigue and how things have been for her during the pandemic. So look, I'd really like to thank Novartis for offering to sponsor this webinar. It's been hugely popular, and I think that reflects the impact this symptom has on our patients and the MS community. We're going to start with some presentations. We've got loads of time for questions and answers, so please do use the question and answer box to ask any questions that you'd like. That's open for the whole presentation, so you can start straight away putting your questions in there, and we'd be delighted to try and help you with those. The meeting closes at 1 p.m. There isn't an extra seminar, so just a quick hour to help you and your patients manage their fatigue. So what we're going to do today, hopefully for you, is to provide a bit of an overview of the pathogenesis of MS-related fatigue. This is a really complex area, and Emma's going to help us to work all that out in our heads. But probably more importantly for most of the people on this webinar, we're going to look at how in practice we investigate and manage this in clinical practice. So we do have a very basic case structure just to help us with this decision. Zoe, this isn't Zoe's experience. This is a number of patients that we've looked after, but just to give us some focus as to what we're after. So our patient is a 28-year-old lady who complains of a recent onset mental fatigue and having difficulty coping at work. She's a solicitor, and she was diagnosed 2 years after presenting with optic neuritis. She started dimethylphenidate 18 months ago and has been relapse-free. How are we going to investigate and manage her MS-related fatigue? Over to you, Emma, to how we might be thinking about things.
Thanks, David, and it's a pleasure to be here. So I think, so I'd just like to show my disclosures, and then if we could go on to the first slide. So I think that although I've been tasked with giving an overview of the pathophysiology of fatigue, so in other words, what is it that causes fatigue in people with MS, I think we have to acknowledge this is a really challenging subject. And although David might hope that I'm going to give you this kind of comprehensive understanding to, oh, well, that's why people get fatigue, I think in honesty, we're still trying to disentangle that. And I wanted to show a figure in a second to sort of explain why that is. And I think, an important point is probably being honest with our patients about that, because, when they come and say, well, why am I having fatigue? Is this dimethyl fumarate going to stop fatigue? If I stop work, will that help my fatigue, and so on? I think often the answer to these questions is that we're not sure, that we don't have really very good evidence. But I think if we can try and share our understanding of what we do know, then that's helpful. This is sort of distilled out. This is my own kind of flow diagram just to help me conceptualize fatigue and its causes. But this has been sort of distilled out from various different nice reviews that are out there on trying to disentangle, what's under the surface in the brain, particularly causing fatigue. But if we just think about it from left to right, so on the left side of the diagram, we've got focal and diffuse white matter pathology. So what does that mean? Well, in the brain, as you're well aware, if we look on an MRI scan, the white part of the brain, the sort of white matter of the brain, which is the inside part of the brain really, and not the outside cortex bit. The white matter of the brain, has areas of previous inflammatory demyelination that we can see on the scan. But there's also this recognition that actually, if you look at the brain down the microscope, even the stuff that we would call normal in between the lesions is actually microstructure a little bit abnormal. So that's what we mean by this sort of diffuse pathology. So we know that both those things are happening in MS, in the brain, and it's almost certainly going to lose connectivity. So the brain is obviously like a huge wiring structure, and if there's impairment in the way that different areas are connected, then that might lead to certain effects. So there's this thing called recruitment, which has been recognized in imaging studies, and that means that if I'm trying to do a task, my brain will recruit certain areas to do that task well. And if we look at people with MS versus people that don't have MS, we do see that the recruitment of the brain is altered in doing the same task. And that probably means that the brain is sort of saying, well, the normal channels that I would use aren't working correctly. So I'm going to sort of think laterally, if you like, and recruit other areas of my brain to do the same task. But the point is that that can be quite inefficient. Because whereas you might only normally recruit one little circuit, if you're having to recruit a really wide circuit just to overcome and sort of adapt, then it might be a little bit energy inefficient and therefore more exhausting to do that. And then there are certain pathways in the brain that we don't really think about, but the arousal pathway is the one that keeps us awake, and that is a neurochemical pathway. And if that happens to be disrupted by lesions or diffuse pathology, then perhaps we will feel less wakeful. So that could be part of fatigue. There are sort of pathways to do with planning. So if I was going to make dinner and I had to plan a recipe, go to the shops, perform my shopping, which is kind of complex task, and then come home and follow quite a complex recipe, there would be quite a lot of sort of motor planning and execution in doing that. And if that particular pathway is disrupted, then that whole process might be more fatiguing, if you like. And then also an interesting one that I hadn't really thought about, but actually the reward circuits. So, there are circuits in the brain that when I have a bar of chocolate, or if I go and meet my family and have a lovely day, I get a kind of a pleasure from that, which if you think about it, is also a chemical thing. So, there are certain chemicals like dopamine and others that are really kind of involved in giving you reward. And if something like that, as an example, becomes less fulfilling and rewarding over time, then you might feel demotivated. So why bother cooking a nice meal? Why bother going to meet family? Because I don't find that such a rewarding experience anymore. And that might be to do with those circuits. So I think there are quite a lot of ways in which even just the stuff that we can see on the MRI might disrupt the brain in a way that causes fatigue. But actually, there's a lot of pathology that we don't see on the MRI. So if we look at the next purple rectangle, it talks about grey matter pathology. And we don't see this very well on the scans, but we know down the microscope that parts of the brain that don't actually have a whole lot of myelin in them, like the cortex, are still affected by MS, by this demyelinating disease. So, for instance, there's a part of the brain called the hypothalamus, and that's really important in sort of wakefulness. So you've probably heard of something called narcolepsy, and that's a condition where people have a problem with the hypothalamus, particularly the cells that produce this chemical called orexin. And again, there's been some evidence in MS that chemical is also slightly disrupted, and it might lead to that kind of feeling of difficulty with wakefulness. Likewise, I've already mentioned dopamine, which is what DA stands for, but other things like serotonin and so on, there's been evidence to suggest that those sorts of chemicals can be affected in the brains of people with MS, probably because the nerves that secrete them have been affected. So I think those sorts of chemical disruptions might well be relevant. And then finally, we have to sort of remember that often inflammation is upregulated in these people, particularly in the central nervous system. So, there are lots of measures that you can do in the spinal fluid and so on to suggest that there's this constant sort of inflammatory state. Now, obviously, that's what we try and suppress with things like disease-modifying therapies. But while that's going on, if you think yourself about when you've got some sort of inflammatory process going on in your body, whether it's because you've got the flu or whether it's because you've got an area of inflammation on the skin or something, but if it's causing sort of systemic activation of your immune system, it can make you feel quite fatigued and so on. So I think that in itself, even if you had a sort of a pristine brain in terms of the white and grey matter, might lead to fatigue as well. So it's quite a complex diagram, but I think sometimes the complexity is worth trying to communicate to people so that they sort of understand that actually affecting little different bits of these different pathways might have sort of marginal gains in improving fatigue. And if we just go to the next slide, that's what I wanted to talk about next before I hand over to Joe. So I think management, how can you summarize this on one slide? It's difficult, but I think because we wanted to maximize discussion, I did just want to briefly summarize this, and then we can perhaps come back to areas of it if it's of interest and you post questions. So I think one of the key things is, it's going to take time. So there isn't a sort of a quick, knee-jerk response we can do in the clinic room when someone says they have fatigue and you say, fine, I'm going to give this medicine. I think it does require knowing the patient, and this is where the involvement of the multidisciplinary team for me is so key. So I really do rely on the help of the MS nurses, people like Joe, who's going to talk to you in a minute, who's an OT in Cardiff, and sometimes physiotherapy and psychological therapy as well. So but some of the considerations that I would already make in my own clinic room as a doctor would be someone's general health. And I think it's really important not to attribute everything to MS. So it's important that we don't miss someone's got thyroid dysfunction, anemia, or some other condition that can coexist, B12 deficiency and so on and so on. So I think there needs to be a kind of a general medical screen that we don't keep repeating and repeating, but I think we need to have thought about that at the beginning. I think the thing with medications is very tricky because some of these medications are often used to treat things that can disrupt sleep, for instance, pain, the bladder, spasticity, and so on. And I'm going to come on to say that I want to try and ensure that people with MS are getting a good night's sleep. So I think there can be a bit of a catch-22 where we're giving medications that can cause sedation, but we're actually giving them to try and improve their nighttime sort of sleep health. So I think sometimes going into that in quite a lot of detail about understanding when in the day they should take the medications, when their symptoms are worse. I think I often encourage people to explore missing doses of medication, increasing doses and so on, and kind of understanding that there's going to be this balance to strike, and that if someone, is trustworthy, that perhaps they could just tinker with the doses to try or the timings to try and achieve that balance. So coming on to, I haven't spoken particularly about medications such as Amantadine and Modafinil, but we could come back to those in the question and answer if people are interested about those. That I don't think they're a kind of a mainstay of managing fatigue, I have to say, but I think there are certain situations where we might try them and we could address that if people want to know about that. I think sleep is a really important thing. I think we need to understand how much people are sleeping, but also how good quality it is. Do they feel refreshed when they wake up? Is a good question to ask people. How their sleep hygiene is, and what I mean by that is, are they working shifts? Are they going to bed at erratic times? Are they napping for long periods in the day to the detriment of their sleep at night? Or is their napping used in quite an effective way? And then moving on to mood, there's this really complex interaction with someone's mood and someone's fatigue. So, it's really worth trying to think about optimizing someone's mood if possible. And there are certain antidepressants which I think there's reasonable evidence can impact positively on fatigue if someone's also depressed. I think Joe's going to talk about sort of general health, including, things like diet and exercise. And I think Joe's going to talk a lot more about things like this, but I would certainly be looking in my local area for what's available in terms of some either self-management or some group-led work to do with sort of education about fatigue and kind of self-efficacy. So I think I'll leave my discussion there and hand over to Joe, who can perhaps expand on some of those issues. Thanks.
Thank you, Dr. Talentay. I'm Joe, and I'm occupational therapist working in the team. This is my declaration. So yes, there are some important things to consider with this case study, and a lot of things already Dr. Talentay mentioned. We are looking at the young woman with the mental fatigue, and that fatigue impacts her ability to work, which is very important. So it's, as Dr. Talentay said, it's important to understand where that fatigue comes from and what type of fatigue we are dealing with. We all know when we're doing something physically, we have that physical fatigue, and that's fine. But then when we also add some cognitive function into it, especially cognitive overload, that can become a little bit more tricky to say what is the mental, what is the physical fatigue, and how they are different. Well, they are different, but they're also very interlinked. So it's always remember when we're talking about the mental fatigue, to look at the physical fatigue and see if that was one of the triggers. So a symptom of mental fatigue can include like a mental block, lack of motivation, being irritable, stress eating, and that important lack of sleep. And that all can sort of impact on everything we do in our daily life, and that's obviously include work. So what can we do? And sort of my role is to establish the difference and what's happening and how to help person to manage it. So I have a little different diagram for myself. And when I get the referral, I start from the basic. We work as a part of big team, and I rely on the team to make sure that everything medical been sort of eliminated. So as Dr. Talentine said, all those things that can sort of go wrong and cause fatigue from medical point of view, like anemia, iron deficiency, or lack of vitamin D, and also the side effect of the medication, all that be normally looked at before the person sort of gets into me. So I rely on the whole team to sort of complete those investigation and address if necessary, either through themselves or it might be sort of referral to the GP to review some of those things. And then I start sort of from collecting some general information, because it's all about knowing the patient. So I look at their lifestyle, how their life look like, what they dislike, how their family life look like, how their environment look like. And I also look when the things start to become an issue. When it happened, how is it happened, and what was the presentation? Was it disabling, and how? So in that case study, we look at work itself and the tasks that are required for this lady to sort of perform whilst working, but also looking outside work will be very important. Then we look at the activity analysis. So we'll ask our lady in the case study to complete something called fatigue diary. And I don't ask you to do it for one day. I ask minimum 4 to 5 days, and mixture of the weekdays and the weekends, so we can see how it's different. So what's happened then? We start understanding the triggers of the fatigue. And I also ask a person to rate and how it's different between one task to another. I encourage that because it is a self-assessment tool. So people can actually see what's happening. They can reflect back. And very often, by the time they sort of finish that fatigue diary, they come in and say, well, I can see what I'm doing. I'm doing so many things in early in the morning. And then obviously I don't have no strength in the late in the afternoon. I also ask them to, they can self-score on the mental fatigue scale, and that's actually quite a good reflection as well, to sort of give them that permission to say, well, actually, the score is showing that I am exhausted, I must be exhausted. So it's again around that sort of permission and self-reflection. So then what I look in the fatigue diary, see if there's a pattern, but also if there's a changes. Is the new work started? Is the new workload started? Is there maybe a new responsibility environment? Maybe there's a different office or lack of the office. Maybe they've been told to not come to the office. Is the staffing level change? Is it the work demands change? So looking at all of that. And then we move to very important sleep. Sort of break it down again, look at the routine, bedtime hygiene, and again, encourage to do some self-rating sleepiness scales, which are really good reflection. And then I look at everything what's been done so far. So if there's anything been helpful, if it does, why it's not helpful anymore, are there some support tools and mechanisms in place, and how effective are those? But also the routine or absence of the routine. And the sort of next stage, which is the final stage, is the intervention. So in the interventions, that's some things that I would offer. So first of all, signposting. So we have fantastic MS Society, MS Trust, wonderful resources there that they are normally a really good start. We will then discuss some virtual resources and courses like the Fatigue Applying Cognitive Behavior and Energy Effectiveness Technique for the Lifestyle, which is an evidence-based group program for people with the MS. But just be quite wary that there is some cost involved in that. Or OMS7, which is a 7-step program, again, designed for people with MS. And then I'll look about what we have regionally. So we have things like Valley Steps, New Horizons, which are sort of local for us here. But we also have occupational therapy-led living well groups and neurorehabilitation groups for the wider people of the neuro conditions. But those normally include something around the fatigue management. And if we try all of that, and then nothing sort of comes up from that, then there's the time for the one-to-one sessions with myself. So in my session, we start from learning. So it's about that analyzing, about again sort of utilizing those fatigues diary. Where did they take us? What is your scores for your sleep? What is the score for your mental fatigue and the physical fatigue? Looking at those. So I sort of go through the circle of the analysis of the previous slide. The huge part of the intervention is an education, but it's not only about how to manage fatigue. There's, like Dr. Talentine said, there's no magic wand and a magic spell, and I can say, well, there we go, that's what we're going to do. It's about actually learning and looking at all those things like mood, like sleep, diet, exercise, stress, everything together. But also finding ways about implementing energy conservation for those high energy consuming tasks, and implementing my favorite 4Ps, which is planning, prioritizing, prevention, and pacing. And then it's the education, but it's not also education to the patient, but education to others. It's important that we empower our patients and give them permission to implement the change. And that's often involve the environment and people around them to understand what is happening, understanding how that fatigue works, and what challenges it poses, but also permission about the implementing a life-changing, the healthier lifestyle. It's a time for a self-care, to practice mindfulness, relaxation, CBT, ACT, or energy preservation. So what can be done for the cognitive fatigue at work? So that's again coming back now to our case study. So we start from the physical demands. Can the work be done sitting down? Can we limit the travel from the office, but also maybe between the offices? Very often people will move between one office to another. Is that necessary? How far are the toilets? That's really important. And the kitchen facilities, lunches, and so on and so forth. And we look at the job specification. As the person doing just the one work, or more than one person because they're a bit maybe short of staff. Then we will look at the mental demands. We eliminate and decrease distraction, task switching, multitasking. We try to do that cognitive offload, use the planners, reminders, whiteboards, calendars, anything that then can allow us to focus on the one task at a time and allow that space for other cognitive tasks to happen. In the jobs like that, maybe utilizing dictation, ask someone else to obviously do the typing. That will save quite a lot of energy, and minimize the social interaction. Yes, it's important to socialize, but actually it takes a lot of energy. So then we look at the environment. So again, position, office, workspace setup. Can we do anything better? Access to all the tools required to do the job. You use the lighting, screens, the blue light illuminators. If they are in place, they can save us a little bit of energy there. We look how we can adjust, being reasonable, advise patients to do what they need to do, not what others expect them to do. And that's quite difficult for a lot of our patients. Plan regular breaks, obviously that's the most important. Take the time to enable that energy restoration. So it comes back to that again, fatigue diary, looking at what we do, what time, and how much energy it takes. Looking at simplified tasks, what can we done easier? Because sometimes we just do the things because that's the way we always done them, but that doesn't mean actually that that's a good way of doing it, and definitely doesn't mean that we can save the energy there. So we're using energy when it's not really required. Personal approach makes a massive difference, and the positive attitude of the person. If we have a doers and I can try it, they normally the best people to work with. If not, can we support our patient to become one? Can we be that support of saying, right, okay, let's deal with things effectively with all the demands and the challenges. Let just don't say no, I can't do it. Let's see how it can be done. And then we're looking at available support. So what is there? Can access to work help? Maybe paying for the taxis so the person don't have to drive to work. Other the team secretaries, assistants, students available to take some tasks from the caseload, but also outside work. If the tasks are at home, can be prioritized and maybe delegated, there will be more energy available to just focus on work and address those work demands. And then we talk about the realistic goals. They are the key. They are require time. Nobody can just, set up the goals, because if they never done them before, it's quite difficult, because it's changed the way of thinking. Start very small, don't giving up. So again, promoting and giving that encouragement, and promote self-efficacy and permission for self-care that I mentioned before. And of course, the last one is to educate. Again, it's about empowering patients to talk about the MS to the people around them. So this is me. Thank you very much. I will pass you back to David.
Oh, thanks so much, Joe and Emma, for really exceptional presentations. And we're getting lots of questions coming in through the Q&A sessions that we'd be delighted to take. Just before we do that, Zoe, do you mind if I come back to you and just ask you, does this ring true, what Emma and Joe have been telling us about, and does it correlate with your experience?
Yeah, absolutely brilliant. Before this session, I thought, oh, they'll definitely not know stuff about grieving the person you were and all the mental stuff you go through, but you totally understand it. It was really great to hear that it's not just a physical thing you can see in the brain, but, you know, people do understand all the other bits you go through as well.
And Emma's diagram with all the sort of ways in which fatigue could be caused, did that correlate with something in you, or is it not right?
Yeah, especially I'm a real extrovert and I love spending time with people, but that is so exhausting because you're having to explain yourself. You don't know if you're going to have brain fog and be embarrassed when you can't answer a simple question. You don't know if you're going to make it to something someone's invited you to, and then you're going to let them down. So the social side of it can be really exhausting. And it was interesting that that was sort of on the list of actually in the brain. It can be exhausting.
And Jo's mentioned some things about how she advises people to help their fatigue. Do any of those ring true with things that have helped you, or the things that you think are a bit of a waste of time? What were your thoughts about that?
Yeah, definitely. The preserving your energy and not thinking, oh, I've got loads of energy in the morning, I must do everything as soon as I get up because that's when I have my energy, when actually you probably could spend it better and then not be too tired to cook dinner. That kind of understanding your levels. And yeah, it was all absolutely brilliant. I'm going to watch it all again.
Well, very good, very good. Well, look, we've got some brilliant questions and answers coming through. Everyone at home, please feel free to send anything that you want answered in. We've allocated ourselves plenty of time, and we're all really happy to help. But I'll start from the top. So Kamel Sharabim has asked us two questions. The first that I think maybe we all have a bit of a thought about. Kamel mentioned that commonly MS patients complain of sleep disturbance and interruption that exacerbates fatigue. What measures would you advise, and is there a role for pharmacotherapy? Emma, do you have thoughts about sleep disturbance and how we can help our patients?
Yeah, I mean, first of all, I think it's good that Kamel highlighted it because I think it's a really important thing to ask about. So, you know, and we can often find paradoxically that people can be really fatigued and yet not sleeping very well. So I think there are some things that you can do to control that, and there are other things that are very difficult. And some people have historically just never been good sleepers, never felt particularly refreshed, and so on. And you know that can be difficult to address. But for sure, I would say that, you know, I would ask people about, in a lot of detail, about their routine of sleep. So I want to know sort of when they're going to bed, what their sort of, you know, what time they would put their light out, if you like, you know, how long it then takes them to fall asleep, whether they then remain asleep or whether they're getting up. If they get up, why are they getting up? So is it toilet trips? Is it because of pain, spasticity? Are they waking up because they have thoughts, you know, ruminating about things, worries and that sort of thing? And then again, I would ask, you know, what time do they set an alarm or not? And if they set an alarm, are they kind of awake before the alarm, or are they relying on their alarm? And can they jump straight out of bed or need to spend? So it's quite a long kind of discussion. And again, this is why I think managing fatigue can be a bit of a marathon rather than a sprint, because in the first consultation of meeting someone, you might not have a chance to go through all of that. But eventually, when you've dealt with some other things, you know, we can then come back to it. And if you're lucky enough to have someone like Joe in your team, which we're very fortunate to have in Cardiff, then, you know, you have someone with the expertise and perhaps a little bit more time to focus on that. But I think even in a doctor or nurse consultation, you know, we could get to that. So those are the sorts of things I think about with sleep. And then I think I would sort of try and troubleshoot each one. So I think if it's bathroom trips, then of course we need to think about continence advisor, or, you know, at least understanding what the problems are with the bladder, and have they, you know, emptied fully before they go to bed? Are there things we could be doing like catheters to help them empty and so on? And likewise, I would troubleshoot spasticity or pain and so on. And I think really only after all of that would I even start to think about, you know, as Carmel mentioned, sort of pharmacological therapies to put someone to sleep. I mean, I think it's generally something that doctors just really sort of err away from, you know, mainly because of the days of using things that can be addictive, like, you know, benzodiazepines and so on. I mean, one thing that I would say that I'm starting to have conversations with people about is melatonin, you know, because it is quite a natural sort of remedy compared to something like benzodiazepine and those sorts of things. You know, it isn't something that can be prescribed for people with MS and difficulty sleeping, but interestingly, it can be prescribed for other conditions. So at least there's a bit of a precedent there. And, you know, I think I've used it myself with jet lag and I have really benefited from it, but I understand that not everybody does. So I think, you know, thinking about that as a real last resort, you know, I'm aware that it's something that people can go and buy for themselves and it's not hugely expensive and it's not particularly dangerous. It is a hormone that all of us secrete from our own brain. So, but you know, again, I think that should be done sort of probably with the advice of the doctor. Yeah, so that's what I think about sleep.
Oh, brilliant. And Joe, does sleep come up in your assessments with your patients? And what sort of advice or things can you do to help your patients?
It does come up. Obviously, it is part of sort of when I gather the information, sleep is one of those things that I ask, you know, as soon as someone says, you know, I'm absolutely exhausted, the first question would be, how do you sleep? And normally it's always just sleep 3-4 hours. Okay, let's talk hour by hour. How do you get up to bed? What's your bedtime routine? And very often I find there is none. They're, you know, falling asleep with their phone on or the television on. So we obviously start from there, and then we look what's happened when they getting up. So again, like Dr. Talentine said, we look at, is it they getting up because they need to use the toilet, or is it something waking them up? Sometimes it's a cat and the dog. Sometimes the resolution is very simple. Sometimes they can't just sort of put the finger on it. So I ask them to tell me what they do when they get up. Can we change that? There's a lot of research talking about restarting the bedtime routine. So when you get up and you cannot fall asleep anymore, you shouldn't be just lying in the bed, turning and tossing. You should be getting up and sort of restarting that routine. So prepare your body again for a sleep, because the body didn't really rest it. And it, you know, feels woken up in the middle. Although we feel awake, our body is not ready for getting up yet and getting on with our day. So looking at those things, so definitely a lot of conversation then, and trialing things like relaxation, meditation, mindfulness. I do understand it's not for everyone, and I never say, you know, everybody should be going on the same path, because everybody is individual. But it's about being open-minded and being prepared to try things, you know, doing that self-help, because obviously they came to us with the problem because they want that help. So this is the things that we can recommend. Let's try it. If it doesn't work, then let's see what else we can look at. But yeah, you know, I just sort of break it apart. I'm an occupational therapist. I can't help.
Well, that's really helpful. Zoe, have you got any thoughts about sleep, or sort of thoughts about Kamal's question about sleep disturbance and exacerbation of fatigue?
My personal sleep disturbance is down to pain and spasticity, and there's lots of things I can do to get around that. If I have a bath before bed, that often really helps, and things like that. But a lot of it is, I think, that kind of the grief and sort of shame that, so I get really anxious sometimes, and I'll wake up and think, why do I feel like that? And it's because you think you're letting your family down because you weren't able to do what you know, you weren't there for your children today, or whatever it was. And I think, so it is a lot of mindfulness is really, really important, and learning to come to terms with having MS, maybe not working, maybe you know, not being able to do some things, but concentrating on what you can do, because it just comes over you, that anxiety, when you don't expect it. And quite often when I'm having sleepless nights, that'll be why.
Thanks very much. Cabell's got a second part of his question as well. Is there any evidence that high dose vitamin D is helpful to combat fatigue or reduce relapse? And he suggested a dose of 5,000 international units. Emma, any thoughts on that?
Yeah, I mean, I'm not aware of evidence specifically around vitamin D and fatigue. It is something that I always think about when I do that general medical screen, because I think, I tend to recommend for people to think about vitamin D. I think that where we live in the UK, not getting an awful lot of sunlight, there are probably some general health benefits to taking vitamin D supplementation. And, there is obviously a kind of a UK a nice paper from Ruth Dobson and others that sort of made a bit of a UK MS recommendation for 4,000 to 5,000 international units a day for everybody with MS. So I do tend to go along with that. I often check people's vitamin D once at the beginning before they start supplementing, because if they do happen to be deficient, then sometimes they can be prescribed vitamin D rather than buying it themselves. But I'm not aware necessarily of how much of a direct impact it has on fatigue. But I think it comes back to what I was saying before, that I view managing fatigue as a kind of a marginal gains process. So I think that if you can do a tiny bit in lots of different areas, then maybe overall it'll kind of take people to a slightly different level of functioning. But I don't think there's any one area that you're going to target, like vitamin D as an example, and say that's fine, my fatigue's gone away.
Yeah, I think I'd agree. It's often the other way around, isn't it? That you find vitamin D, a low vitamin D, replacing that might have a marginal impact on someone's fatigue. But I don't think I've found that people who put themselves on super physiological doses, that they notice much of a benefit above that. Kate Lavender's got a question for you, mainly Joe. You mentioned 2 programs in your talk about for fatigue management. Would you mind giving all of us and Kate the name of those programs if they can come to mind?
So the first one was Overcoming MS 7-Step Recovery Program. I can find a website if we need to, but if you put that into the Google search, that should sort of come up, and you can read about the program itself, and there is a book available as well. I'm not promoting it, I'm not having any part of the sales or anything, but the book is actually free for people who have got MS. But they have the actual program has got addressing different things like a sleep, diet, exercise. So step by step takes you. It is a self-management tool. So I very often direct people to have a look at it, have a little bit read, come back, and then we can discuss. The other thing I was mentioning was FACET. So it's FACETS. So it's fatigue applying cognitive behavior and energy efficient techniques of the lifestyle. A very long name, but if you just type FACETS, it again comes up. And then it's a group program for people with MS, so it's not just you actually participating in the groups, but there is some costs, and just for people to aware, I always say about it, but it helps you to sort of what they do in that program. They look at the fatigue from the personal point of view, give you the general tips that can help, and the general things to look at for the person to be able to sort of self-reflect and look for the things that are their own triggers and the things that they can improve based on that.
And Joe, you would have thought about these programs in quite a lot of detail. Do you have any advice for us as to which program might be suitable for which patient, or whether you should start with one and then move to the other? What are your thoughts about that?
So I think, before I am aware that there's a cost involved. So before I tell people go and pay and sign up for something, I tell them to start from MCS, do a little bit of reading, see what they think, try things. If they lucky to live in Cardiff and Vale and Clontarf, I tell them to come to our groups, which I lead, and we cover a lot of those things in the group. They are 6 weeks programs. We just finished our first virtual one. We had last Thursday coming, and we cover a lot of things that are very similar that the Overcoming MS 7-Step program covers. So they have that opportunity to come in and join the group if they're here. So I normally say to start from that because it's free, and a lot of people, I don't think I would want to commit myself to something if I don't know if it's for me. And you also will come in with some sort of understanding what you're looking for and try the things by then, the things that work or not. you know, the MS Society and MS Trust, lots of information, lots of tips there. So, you know, I say go and have a look, see what you think. We do have those fatigue management booklets that we can send as well for people to try. And it sort of starts off this sort of conversation. What did you try? What did you work? Why you didn't work? Maybe you didn't try the way maybe I would recommend that you try. Let's have a little rethink about it. So yeah, definitely. Sorry, I'm sort of going off track. Try with the one which are available free of charge. So like OMS or MS Society or MS Trust resources before sort of committing.
Perfect. That's really helpful. And Zoe, you were nodding to some of those. Have you found anything like that to be helpful with your journey?
Yeah, there's on the MS website you can join. It's like a little pod group on a Thursday night, and it's just other people just chatting together and giving each other information, and that's really nice because you don't feel so alone then. I haven't done any of these courses, but I've written them down. And they look really interesting. But yeah, there's loads of things on the MS websites that are really helpful.
Perfect. Thank you very much. So Emma, there's loads and loads of questions, and you very, very carefully didn't make much of a deal about the symptomatic medications for fatigue, but our audience have asked us lots of questions, specifically with respect to both modafinil and amantadine. Do you have any thoughts about where we should be using those medicines, and any advice for us on how to do that?
Yeah, I mean, I think it's a common question we get asked. People have often done their own research and they come, you know, asking about these medications by name. I mean, I think there's a few things to be really aware of. The first is that, you know, neither of them have a license for the treatment of people with MS and fatigue. And I think that's particularly important to say for modafinil, because actually the license was specifically changed on the basis of safety findings. So, you know, the safety findings that we worry about with modafinil are cardiovascular, you know, psychiatric in terms of mood change and skin reaction. So they're not insignificant things. And, you know, that's why the license is now restricted to people with narcolepsy. The other thing that I try and explain to people is that modafinil, the way that it works, when I was talking about the hypothalamus before and orexin, that chemical that's relevant to narcolepsy, modafinil is working on wakefulness. So if someone feels mentally fatigued, you know, and even physically fatigued, I wouldn't expect modafinil to help. I think, you know, in narcolepsy, it's helping to keep people awake rather than them falling asleep. So if they're falling asleep in their dinner, that's a different sort of a description than most people's description of fatigue that I've heard about in MS. So I feel like those two things are really important to kind of set people's expectations, because what they've often, you know, learned from their research on blogs and so on is, you know, an anecdote about someone who took modafinil and felt great. So I think we've just got to be quite careful about setting people's expectations. And because I think naturally people feel a bit like if something's being withheld from them, you know, it's something that if they could only get hold of, it would solve all of the problems. And I really don't think that's true for modafinil, actually. So I tend not to prescribe it at all. The other problem we have with it is that GPs will obviously not continue prescription. So if you start a specialist prescription, you know, then the patient's left either high and dry when the GP says, I won't carry that on, or, you know, you're in this difficult situation where you're trying to provide, you know, a long running prescription for potentially hundreds of people from your secondary care point. So I think there's lots of reasons why modafinil is very difficult. So without wanting to sound too sort of negative about it, I basically don't prescribe it. And then amantadine, you know, is another one that, again, I would say that it's probably a bit more to do with wakefulness. I think there's a little bit more suggestion that amantadine might kind of heighten your brain's response to certain chemicals and therefore make you feel a little bit more kind of responsive and alert and so on. I mean, amantadine, I would probably say, has a slightly better safety profile. You know, it is used in Parkinson's disease for slightly different reasons. So we've got kind of a little bit more experience as neurologists of using amantadine, so I'd probably be a little bit less averse. And my approach to amantadine is usually to give a trial of it. And then again, you know, some GPs will be willing, if the person responds to the medication, to then carry on the prescription. But GPs, you know, won't universally be willing to do that. So you have to kind of understand that and whether you're willing to take on the long-term prescribing of that drug, which not all secondary care providers can. You know, not all MS services really have that. So I think with amantadine, you know, it's also really important to set people's expectations in that I suspect many people will try amantadine and not feel much better. And in that case, it wouldn't be worth persevering with it. So I would see it very much as a trial.
And do you have a thought about a particular patient type or a type of symptom that might respond particularly well or particularly badly to amantadine? Or...
Yeah, I mean, again, I would say sort of wakefulness, you know, so I think if people are really struggling because they have to nap so long in the day and so on, you know, because obviously the whole thing with amantadine is you take it sort of breakfast time and perhaps lunchtime, certainly no later than about 2 p.m, because if you do that, it might actually disrupt your sleep at night. So it is this kind of medication that I see as trying to keep people awake. So again, I would try and set people's expectations that they may not find that they're sort of mental fatigue and stuff is bad. But I think if someone's having to just nap so long in the afternoon or the day that they're just not able to kind of engage with normal activities, then perhaps amantadine might help them stay awake.
That's really helpful. Someone anonymous did mention that the NICE guidance says to offer amantadine for fatigue, which I think can help with discussions with general practice because it is in there. But you're quite right. Modafinil is not licensed and isn't mentioned in the NICE guidance. My next question's for Joanna, and quite a few people have asked this. Joanna, would you mind repeating your 4 Ps, please?
We'll come back to that question.
We'll come back.
So you can text them to me and I will write them in the chat. The other thing I was going to say, actually, just as a bit of a filler, was that when we were preparing for this, Ruth Stross was another person that was really, you know, helpful in kind of advising. So an MS nurse from Epsom, I think that's right. And you know, we were kind of exchanging our own thoughts about the sort of resources that we give to patients and so on. Because I mean, I'm pretty useless at knowing the resources, and I have to say that because we have Joe and we have an MS psychologist in the team, you know, we're really lucky to be able to give a little bit of support in-house. But you know, the only thing that I would tend to sort of hand out is the kind of MS Trust booklet on fatigue. But one of the things I was going to say, that if other people, you know, we've got quite a lot of, well, 90 odd people on the webinar. I think you sharing your own resources that you've come across, you know, that you found people have said are helpful would be really useful. So feel free to share those in the chat, I would say, with the other attendees.
Yeah, please do. And we've got a couple of good suggestions for guidance already.
I think I'm back in.
Yeah, brilliant, Joanna.
Yeah.
Joanna.
Sorry. So the 4 Ps.
4 Ps.
Okay, planning, prioritizing, prevention, and pacing. So plan the task, think about what needs to be done, and if that definitely needs to be done, prioritize again. If it doesn't need to be done, nobody dies, leave it for tomorrow or the next day. Prevent, so prevent anything happen. So good sleep, good diet, good hydration, exercise, get out on the fresh air, okay? Try to prevent that fatigue to happen, and then pace yourself. Nobody said that the shower needs to take 5 minutes. If it takes an hour, it takes an hour. If you don't wash your hair the same time you shower, you don't wash your hair the same time you shower. If you brush your teeth at 10 o'clock, you brush your teeth at 10 o'clock. There's the rules of the society, but that doesn't mean that we all have to apply to them. Okay, so just do what you think you need to do, not what other people do think. So yes, that's the 4 Ps. Sorry, I got it back the mic.
Perfect. Thanks, Joe. Now, Joe, don't mute yourself, because I have another question for you. So Deborah Barkworth has asked, have you got any tips on how best to manage fatigue in patients who are less cognitively able to self-manage their fatigue?
So managing people who have some cognitive difficulties, the best is via routine. So if we can establish routine, so we don't overuse our cognition and remember the small steps, it helps in both ways. So having things planned, so getting to that routine, it's not easy, it's going to take time, but make sure that they are the regular breaks, that the things are easy to reach and visually. So when the person who has got maybe some memory cognitive issues, have everything set up on the workplace, on the worktop when they're going to go and do the drink, so they don't have to overthink. But also if there's a chair standing, it prompts them to sit down. So give those visual prompts wherever you can. And I mentioned the diaries, and I mentioned the whiteboards, and you know, all the calendars and things like that. They are really, really useful for a cognitive function, but also to implement those techniques around the management of the fatigue. So Alexa and Google Chrome, they're brilliant to tell you, every hour you have to sit down and have a 5 minutes, or, halfway through the morning, this is your relaxation time, and place your relaxation, make the person who actually participate in it, encourages. But it's again, it's educating the loved ones and the people who are in support. Is it the carers? Is it the other professional working with that person? Very often we have other teams involved, like a community resource team or reablement team, liaising with them and saying, that person has got some cognitive difficulties, but they also struggling with managing their fatigue. Can you make sure that you plan your sessions so they're not all coming one after another, so that person has got that routine and has got that time to have a proper rest, and obviously don't do those high energy demand exercise or whatever task at once. So there's no carers coming first thing in the morning, and then the physiotherapist comes, and then carers come for lunch, and then it's overloading just thinking about it. So stick to the plan, make sure that everybody's on board with that sort of nearly timetabling, and that the person always can look at it and know what's happening, because if it's there, if visually we can see, it's much more easy for us to sort of implement it and participate in it.
Brilliant. Thank you very much. And another question, I suppose, to all our panelists really, but Tessa asked us, other than stimulus control, the 15-minute rule, and other functional sleep hygiene advice, is there any evidence-based practice or research around more natural supplements such as melatonin or CBD use to help with sleep? So I suppose, Emma, you covered that a bit when you were talking about your own experience with melatonin. Is there any evidence to support that, specifically in MS, or any other evidence to support any other supplements that you're aware of?
I mean, I think it's a bit of an evidence-free zone, isn't it? I think melatonin is evidence outside of MS for kind of sleep regulation and so on. And I think it is now in the BNF, and it's, you can use it for kind of sleep regulation in certain situations. But CBD is a difficult one. A lot of people want to know about cannabis use, don't they? Whether it's regarding fatigue, whether it's regarding, spasticity, pain, so on. I mean, I think, again, anecdotally, you find some people have been really helped by cannabis in various forms, including CBD oil. I, personally feel it's a bit of an evidence-free zone, and I'm sort of supportive of having a discussion about it, and I certainly I'm not absolutely dismissive of it, but I think it comes back to what Jo said before about exploring the costs and so on. So I think with any evidence-free intervention, my general approach is, how safe is it? How much is it going to cost? And is there any kind of even low-grade evidence that it might benefit? So things like vitamin D is a bit of a no-brainer, because it's not that expensive. There's some general health benefits, and it's very unlikely to harm you. So I kind of feel quite open about saying to people that I can't guarantee this is going to really help you, but I would sort of recommend it. I think CBD oil, I'm not massively convinced yet that there's much evidence that it's going to help people. But again, it doesn't seem to be majorly harmful if it's taken in that form. Obviously, if someone's smoking cannabis, I would have real concerns about just the tobacco use and kind of the harmfulness of smoking and MS and so on. So I think I would just kind of taper that conversation according to those kind of fundamental principles.
Brilliant. That's really helpful. There's a bit of talk on the question and answer about the FACETS course. So someone has been asking, actually in your local area, Emma and Jo.
I mean, it's probably worth I've tried to sort of clear this out. So I think the FACETS course was the same as what Jo was saying, which was FACE. So FACETS or FACE TS or whatever is the course that's the MS Society course. That's a kind of an intervention. I think they do ask for a donation, but I don't think it's costs. I think that's right, Jo, unless I'm wrong. But they kind of say on there, we recommend that you consider making a donation to the MS Society and so on. But it is essentially free. And it's run through the MS Society. I don't think it's sort of regional. Is that right, Jo? I think people can just self-refer into it through the MS Society web pages. And I think someone kindly posted the link there earlier.
Yeah, and Kate Levins has also mentioned if there's anyone online who might be interested in this, that she mentions an online day training course for healthcare practitioners on the 3rd of December for anyone who wants to deliver the programme in their local area. and that costs £90 plus VAT, but you get a facilitator manual with that, and that's via the MS Society website. So thanks very much for that, Kate. That's a really helpful bit of information for us all. Great. We're almost at the end of our webinar, so it leaves me to thank Emma, Zoe and Joe for a fantastic talk and some really fantastic interaction with question and answers. I wondered, Emma, do you have any last sort of thoughts or points for us in dealing with our patients with fatigue?
I mean, I think my summary is really a couple of things I've mentioned, which is that it's a bit of a long haul, kind of setting expectations, I think, are really important. That, you know, trying to make marginal gains in lots of different areas of life, as Jo really nicely highlighted in her slides, is kind of our approach to this. But I think being quite sort of positive with people. I tend to find people say, oh, there's nothing you can do for fatigue, is there's no treatments for it. Whereas I think what they mean is there isn't really a medication that in a clinical trial has shown benefit. I tend to try and be really positive about actually there's loads we can do about it. It's just that it takes time and it's kind of incremental. And I think the diary that Jo mentioned is so key because, you know, she pointed out sometimes people do that and it's revelationary before they've even given the diary to anyone. So I think those are the important things to set people's expectations at the start.
Brilliant. Oh, thanks. And Jo, any last points from you about things that you'd like us to take away?
I don't think I have anything to add, to be honest. I think I already said everything. You know, being realistic and being honest with your patients, I think that's the most important things. You know, I am a very optimistic person. I have a lot of positive energy, and I try to, you know, say, right, let's see what we can do. You know, showing them that actually, you know, you trust us and you came for help. Let us see what we can do. Otherwise, why are you coming asking for help in a way, sort of? But person that commits, I think, you know, they do tend to commit better if you sort of, you know, take it around, say, right, okay, let's actually break it apart. It's probably going to take months, but you know, what else you're going to do? If you do nothing, it's going to get worse. If we try something, at least we know, even if it's not improved but stays in the same level, it didn't get worse, and that's a positive. So I think, you know, being honest that, yeah, there's no magic wand, you know, unfortunately, but if they're willing to work with you, there are things that we can try, and we can try them together. And, you know, that's the approach I take with my patients.
I actually really like that, what you said, that Jo, about asking the patient to commit to something. I might start using that and saying, you know, what are you tell me, what are you going to change after the discussion, you know, in the next sort of 6 to 12 months, making the point that it is a kind of a longer term, but also trying to make the point that sometimes I think people come to us and look for us to fix things, but I think it is important to kind of put it back a little bit and say, okay, well, what things are you now aware that you can change from your end? Yeah, I really like that, June.
Zoe, any last points for us, or bits of advice, or anything that we should be aware of?
I think if you get your patients to stick to the places like MS Society and the courses that you recommend, and don't let them go off on the internet, because you have to stay positive, and there's lots of negativity. And also, like you say, sticking to things. For me, medications never really hit the spot, but I know if I have a really good diet, for example, if I don't eat meat, it makes a massive difference. I don't know why, but if I eat meat, then I seem to suffer with loads of symptoms for about a week. But I don't know if that's a medical thing or just the way my body works. But your diet is really, really important. And it is about how much the patient puts in and doesn't just come to you and expects a miracle on the day. So yeah, just trying to get them to be positive and look in the right places is what I think.
Perfect. Well, look, thank you so much, Emma, Jo, and Zoe. It's been a fantastic webinar. I actually feel much more empowered in both understanding fatigue and in my approach to manage it. Emma, I think you showed us that fatigue is very complex. There's lots of mechanisms that are impacting on it, but actually in that complexity lies little chinks that we can try and work on, be it in pain, sleep, bladder or spasticity, and we can work with our patients actually with things that we're quite comfortable to manage, just to get those marginal gains. Jo, from you, I've found that this idea of asking your patients to really commit to the treatment, and asking them to do things like fill in their diary, which, as you mentioned, can really be revelatory in helping people understanding their fatigue. And really your problem-based approach and your relentless positivity has come through. And Zoe, I think you've made a really impactful point that that part of this is the impact of your multiple sclerosis on you, and it's really important that we're there for our patients and help them to get through that difficult transition, but that it's really important that we empower our patients to stay positive and are positive with our patients themselves, and ask people to take some ownership of this symptom and work together to get the best outcomes. Thanks so much everyone for coming. I hope you found it really helpful. Please give us any feedback about things that you liked or didn't like about today's presentation, and keep an eye on the MS Academy website for upcoming webinars. Thank you very much everybody. Bye bye.
Thank you.